Give me 2 minutes, I will.
Yeah.
I'm going to put light, so dull it is.
Yeah, Sujata.
Hi, good evening, everyone. We are a mentoring charity, the Mentor Ring, based in Cardiff, Wales, and we mentor individuals in the areas of education, health, employment, and community cohesion on a case-by-case basis. We are here today with Shakila to say something about the Pulmonary Rehab Week. Over to you, Shakila.
Thank you, Sujata. That's so kind of you. And thank you for this opportunity today. And I would welcome everyone to this webinar. And I'm excited to go through the following slides with you in a few seconds. So the topic today is say hello to virtual pulmonary rehab. And we're going to talk about more into pulmonary rehab today, more about the virtual pulmonary rehab. Before I could dive into that, I would introduce myself. And a big thank you for a generous support from Mentoring for this presentation today. And I would like to put a disclaimer. This presentation is not a medical advice, but an information to create awareness on the pulmonary rehabilitation. And any information or approach should be used in discussion with your current provider. Or the mentoring is not making any guarantee or representation that this concentration will be improving your health or prevent possibility of negative outcomes. And this presentation is prepared based on the information at the time of writing, can be superseded by the later developments in the field of pulmonary rehabilitation. So hello and welcome again. And I'm here today to talk about pulmonary rehabilitation in the honor of the Pulmonary Rehab Week, this week from the June 21 to 27th of 2021. And basically this webinar is the main objective is towards raising awareness on the values and benefits of pulmonary rehabilitation for the patients, providers, and the payers. And also to promote an integrated pulmonary rehab care for people with chronic respiratory disease, and to drive implementation of tele-rehabilitation and mental health program for people with chronic respiratory disease. So I'm going to talk about these three main things. So let me actually introduce myself and answer the question, who am I to talk all those things? So 20 years of experience as a physiotherapist, specializing in pulmonary rehab for 9 years in Dublin as a pulmonary rehab coordinator and a senior respiratory physiotherapist at St. Michael's Hospital in Larry, which is my best part of my life in the years of my professional career as a physiotherapist. And I also worked before that as 2 years senior physiotherapist in primary care in the HSA, Ireland. And following that, I was also having a small role in the intellectual disability. And I then jumped on to UK for 22 months. I was in Lancashire Teaching Hospital as a clinical lead in oxygen therapy, and I thoroughly enjoyed that experience as well. And I found my value and destination is in teaching and research. So I had an opportunity to be a lecturer in cardiorespiratory physiotherapy in Cardiff University, which I took on board and had taken a risk of moving from northwest of England to Cardiff in 2018. Apart from that, I have 15 years of post-qualified experience as a counselor and psychotherapist using motivational interviewing and cognitive behavioral therapy for patient recruitment prescription in pulmonary rehabilitation care setting. And I also have a bit of background in clinical research and perspective papers from 2009 to 2021. And people who are more interested to know about myself can visit my LinkedIn profile, which I've just put down below. So without any further ado, I would like to jump into the presentation, ask the big question about what is pulmonary rehabilitation. So most of the people who are watching live or watching this as a recorded version would be from many parts of the world, and you all will be familiar if you are a respiratory pulmonary rehab care specialist. The two main international bodies, American Thoracic Society and European Respiratory Society, definition of pulmonary rehabilitation. It is holistic assessment, design and delivery of an integrated care tailored to patient needs with chronic lung disease. So what is the primary goal of it? What does the definition say to us? The two primary goals are to improve the physical and psychological conditions for patients with chronic lung disease, and also to promote the long-term health enhancing behavior change for patients with lung disease, chronic lung disease. So what is the value? The value of pulmonary rehabilitation has been proven as a gold standard, non-medical, holistic management with the benefits of improved exercise endurance, breathlessness, fatigue, pain, and sense of well-being for many chronic lung disease. And I don't need to justify today that, because many of them have worked in the field, a plethora of evidence exists that pulmonary rehabilitation works. So I'm not here today to prove that. So the components are exercise training, education, and main component, the other third component, main component is behavior intervention, which is a key most role in attaining the exercise training and education benefits in patients with chronic lung disease. So who can be referred to pulmonary rehabilitation? Chronic lung disease, what does it mean? Chronic obstructive pulmonary disease, we are all familiar with this, and it is the major, second most common leading hospitalization in the UK and worldwide, the third leading cause of death. And asthma and interstitial fibrosis, bronchiectasis, obesity, hyperventilation, cystic fibrosis, obstructive sleep apnea, pre and post lung transplantation, and pulmonary hypertension. But the list is never stops here. It is very, very long. All patients with chronic respiratory disease, which are not named in the slide, can benefit and have the value of pulmonary rehabilitation. So why pulmonary rehabilitation? Why it works? So any patients, major studies in pulmonary rehabilitation for the past over 20 years have been based on COPD. And COPD is a chronic obstructive pulmonary disease. Major cause has been the smoking. So I've just put this diagrammatic representation with a picture, man with the smoking, okay, figure. And so because of smoking, what happens, patients having their airways narrowed down, the airways get inflamed and narrowed down. So the narrowing part of the airways is measured in forced expiration volume 1, and the stages of the COPD has been categorized based on that criteria, goal stage 1, 2, and 3, as you can see on the slide. As they're actually having a long history of smoking, they actually end up in a lot of exacerbation, hospitalization, and there is also air trapping in the lung. So in our lungs, there are a lot of small airbags, more than 300 million airbags in our lungs, small sacs, okay? And those tiny sacs are damaged because of the smoke, and that causes a hollow space where the air is more trapped. So the patient's airway is narrowed, and any of the air which is breathing in through the nose is getting trapped in that. As a result, the patient is not able to expel out the carbon dioxide. So the carbon dioxide, which is a bad gas, is actually trapped. As a result, there is an hyperinflation of the lung, and the patients are very breathless. So to explain that, because this video is watched, I'm very well aware with a diverse audience, if the patient is watching it, it will be a more informative information to supply to this as well. So as a result of this inflammation and hyperinflation, there is an increased hospitalization, and the patients have a decreased physical activity. So as a result, the patients actually have the symptoms of productive cough, breathlessness, wheeze, chest infection, and fatigue. So what happens if the patients have this? There is a chicken or egg concept. There is a physical inactivity and muscle weakness. We don't know whether because of the muscle weakness, patients are physically inactive, or because of physical inactivity, patients' muscles are weak. Okay, but still, these two consequences happens as a result of the damage caused to the lung. So The patients, once they have this, they are not able to go out, participate in their normal activity, and they end up in anxiety and depression. And this is a big buzzword in the world. At the moment, each individual, even without COPD, aware of the anxiety and depression with the COVID symptoms. So patients with chronic lung disease have anxiety and depression because of breathlessness and inactivity. And as a result, they are social isolate themselves and go into sedentary lifestyle. And there's an exacerbation of symptoms. And this goes round and round in spiral circle. Okay. And because of that, there is a poor quality of life and patients having disability, and that would result in disease progression, and that would end up in death. Okay, I'm trying to figure out, everything's on the slide shown to you. So this is the spiral of inactivity caused by the chronic lung disease. And what is the role of pulmonary rehabilitation here? Pulmonary rehabilitation lessens the intensity of breathing, and so it decreases their breathlessness and it decreases their leg fatigue symptoms. And it improves their muscle strength and exercise capacity, and it improves their quality of life. It reduces the frequency of exacerbation and improves the functional status, and it reduces the GP visit and hospitalization, but it would not reverse their lung function or the capacity. So what is the pulmonary rehabilitation in theory? So any of the patients with chronic lung disease, most of the people who are watching from the background of respiratory care will be aware of this diagram here. And this is more scientific. And this is how we categorize the patients and refer them to the pulmonary rehabilitation. And it is a gold status, and developed in 2011 and improved in 2017. And the category of A, B, C, D, as you can see on the slide, is based on the major three things: the patient's exacerbation rate per year, and their CAT score, which is COPD assessment test, and their lung function test. And the lung function test is a major test required to confirm whether the patient have a chronic respiratory disease. And based on this category, as you can see on the slides, and I've given the example of how the questionnaire looks like for the COPD assessment test and how their lung functions are divided here. And based on these three factors here, the patient is actually triaged to a pulmonary rehab setting. And for the lung function test, basically, we would be more beneficial if a patient is going for the full body lung function test, which measures their diffusing capacity alongside with the FEV1, which is the forced expiratory volume in 1 second. So the BHF guidelines reference to pulmonary rehabilitation is based on the Modified Medical Research Council dyspnea scale. And that is actually runs down from the grade 0 to grade 4. As you can see on the slide, the person who is having a grade 0 has not troubled by dyspnea unless it's strenuous activity. And the patient actually with grade 4 is very severe dyspnea, still cannot leave the house and not able to participate in any of the extra social activities, and more in a depression and anxiety status alongside with the physical inactivity. So based on those gradings, you can see on the slide, the patients are referred to the pulmonary rehabilitation, grade 0 and 1, to a pragmatic approach, a flexible approach for the patients who are able to attend the outpatient or in the gym, and grade 2 and 3 to the outpatient setting, and grade 4 to the community setting of pulmonary rehabilitation or inpatient community setting. So what are the contraindications for pulmonary rehabilitation? Unstable cardiac disease, if the patient is having a myocardial infarction, and if they are not in a stable condition, optimize the medication and other supplements, they are not prescribed pulmonary rehabilitation. And severe arthritis and severe peripheral vascular disease, any locomotor functional disability who are not able to participate in the group setting cannot be prescribed in outpatient setting, but definitely they can be provided in an inpatient setting of pulmonary rehabilitation. This is not going to exclude them to avail the values and benefits of pulmonary rehabilitation. And the third main criteria is the cognitive or psychiatric impairment, where the patient's not able to follow the instructions, and that condition, the pulmonary rehabilitation is not possible, but with the support of the carer and sign languages, patient with a learning disability can avail the benefits of pulmonary rehabilitation. So how does the journey of pulmonary rehabilitation begin? What is the normal thing happening in every healthcare setting? It starts with an assessment of fitness to enroll in pulmonary rehabilitation. They take your past medical history, the current symptoms, and which I've just mentioned in the slide down here, their lung function tests, their smoking status, inhaler check, exacerbation, oxygen level, exercise capacity and endurance, pain, balance, disability, quality of life, and psychological health. And based on those assessments and their data collected from the patient, the goal setting happens and the pulmonary rehabilitation is prescribed. And when we talk about the goal setting, we're all aware of the short and long-term goal setting, and that's how your healthcare provider works with you to plan a great action plan, which is a SMART outcome. And all the measures should be planned according to minimal improvement clinical difference attained before and after the program, so that is a comparable clinical improvement happens as a result of the pulmonary rehabilitation training program provided to the patients. And the frequency, initially the assessment happens and the patient is prescribed either a 6 or 8 weeks program, and post 6 or 8 weeks they are then assessed the same clinical outcomes, and every 3 months there is a follow-up. And some patients are also put onto a maintenance program to attain the benefits of pulmonary rehabilitation for a long time. So the common pulmonary rehabilitation key performance indicators, the main 3 common key performance indicator, which is in current practice in most parts of the world, is they look into the exercise capacity and endurance, which is one of the key performance indicators they look into. And when we talk about exercise capacity and endurance, it's the cardiopulmonary exercise testing, and which is the gold standard to measure their exercise endurance capacity of any individual. And it requires a treadmill and the other equipments to measure the oxygen level, VO2 max, and so on. I'm not going to go in depth to that, as that is not the focus of our webinar today. And the other test is the 6-minute walk test, which is a common in practice. And the patient is actually walking in a 10-meter distance, and this has been developed earlier by ATS in 2006, which requires a 30-meter distance, but in most parts of the world, we actually get modified to 10-meter because of the resource availability and the space. And so patients allowed to walk, and the parameters like the distance, their symptoms of breathlessness as being noted, and the oxygen levels as they are doing the walking test is noted, and appropriate level of oxygen is also prescribed based on the levels of their saturation noted during the test. So this is the basics of the 6-minute walk test, and the other tests I'm not going to explain in depth. Some of the tests which are most prevalent in most parts of the world is incremental shuttle walk test, endurance shuttle walk test, 4-meter gait test, 5 repetition sit-to-stand test, and most prevalent now due to COVID and virtual rehab being starting up, or already started since the onset of the COVID, I should say. And the most common test used is 1-minute sit-to-stand test and timed up and go test. And some parts of the world use a short physical performance battery. So I'm not going to go in depth of each of the tests explaining here, and that is not the focus. And I just want to make you aware these are the tests available for the indicator of exercise capacity and endurance. And the second main indicator we all actually look into in pulmonary rehab setting is the dyspnea, which is the primary cause or reason the patient is actually coming to us for the support of the care. So the dyspnea scales, most of them actually, the BTS guideline have TRIAGE referral based on the MMRC dyspnea scale, and during the assessment and the program delivery, the Borg scale, which is 0 to 10, has been used, and the other scales are the baseline dyspnea index scale, BDI, and transient dyspnea index scale, and there are more other scales prevalent, but I'm not going to mention as a result of time. So these are the primary most prevalent dyspnea questionnaire being used in most of the setting. And the third main indicator is the quality of life. And some of the quality of life measures, which I've just mentioned here, is St. George's Respiratory Questionnaire and Chronic Respiratory Disease Questionnaire, COPD assessment test, which is the most common and easy to use tool, which has 8 domains and which is more relevant to the symptoms of the patient. And since 2009, it has been developed by J.W. Pauls, and it has been a more popular one, which I use and I love to use in my setting to deliver the care and measure the improvement of the patient. And the Hospital Anxiety and Depression Questionnaire, which is another common questionnaire used to measure the anxiety and depression, which I had also been using in my practice, and the Euroqual 5DQ. And I've just mentioned, to make you aware, a very little summary of different tests available, but the length of the test available is infinity, okay? So it's massive. So you can explore further. So what are we missing? If you could just reflect on the slide, what are we missing here? What is the common key performance factors we are missing? What does the definition say to us? It is a holistic assessment focused on improvement of their physical, emotional, and long-term behavior change. And what are the tools we are using for the long-term emotional behavior change? Where is the mental health assessment in our pulmonary rehabilitation? It is a big, big question. And so the exercise prescription, I'll let you to think about that question and I can answer that in later slides. So now the exercise prescription is based on the FIT principle, and the major exercise training in the pulmonary rehab setting is aerobic or endurance training, resistance training, and circuit training, and interval training methods, and inspiration muscle threshold training for the inspiration muscles to improve their inspiration muscles, the strength of the diaphragm, which is a major inspiration muscle, and that has been strengthened by use of some of the equipments which your provider will be providing in the settings. And the PIT principle, as I said, you need to be prescribing the exercise based on the frequency, how often, and intensity, how hard the training should be, the timing, how long the training should be, and the type of the modality, what type of modality the patient should be using. So when we talk about the frequency, 3 to 5 times per week, minimum 2 supervised and 1 unsupervised session per week, and 60% max work rate, which you can measure by the maximum heart rate 220 minus your age, and take that as 100%, and 60% of that should be achieved during your training program. And the work scale 0 to 10. And the regular, I would actually categorize in terms of the intensity of the workload given, I would actually categorize based on their pattern of the individual. Some of them are regulars in the activity, so they can be provided a timing of 30 to 40 minutes. Some of them will be social butterflies, one or 2 times a week, okay, so 20 to 30 minutes. And people who are very severely compromised, they use an intermittent or interval training of 10 to 15 minutes, okay? So those are the prescriptions which could be considered in the setting to make the training effective. And the type of training, again, this is the picture representation. Some of them, again, it is are a very fit person, and you have to tailor the individual's program according to that. Some of them are severely very compromised, and you have to modify a program. And it can be a walking training for the aerobic pattern. It can be a walking or a cycling or a treadmill. So you can actually mix and match according to your patient population, what actually suits them. It's majorly important that a patient engages with your program. So you have to read your patient and know what matters to the patient rather than what you need to be providing to them. It is not a prescription or fast written on stone. So you have to tailor your program of pulmonary rehabilitation to promote the program values to your patient group. And how to make my exercise prescription successful. And success means different to every individual, and it applies to your patient group and you as a 2 individual interacting in a program setting. So it is a major effort is required. What all we are going to do is a behavior change implementation in your patient group population. As much as possible, my advice would be make it as a fun activity. And some indoor options you can adapt is some apps or pedometer or Wii games, music, dance, yoga, Pilates. Again, when you're using this dance, which is an high intensity activity, you have to recruit a patient population who are fit to do the dance program. And if you're tailoring a dance, it needs to be not a severely compromised patient. It should be in a moderate category or less severe category of patients, your population for the dance activity. And the outdoor options are the pedometer or apps, which can actually suit your patient population. And some of the safety tools for the compromised patients, for breathlessness or getting frequently breathless, fan is one of the options. And some of the patients have a high severe leg fatigue, related, or the step up, as represented in the slide, can be a best option for them. So, what are the postural control breathlessness? So people might not be aware from the respiratory care professionals, might be aware of what you're advising. So this is actually a general awareness webinar. So these are some of the positions we advise to the patient group, as shown on the slide there. So high side lying, forward lean sitting without pillows, and forward lean sitting with pillows, and upright sitting in a chair. Forearms support to assist the breathing while you're shuffling on the trolley, leaning forwards. That will actually ease your breathlessness. So what exactly happening when you're leaning forwards is basically your gravity is acting on your diaphragmatic muscles, pulling down the diaphragmatic muscle, which is actually a main inspiratory muscle, making more room for your lungs, and that is going to improve your oxygenation to the muscles of extremity, and that will improve your breathlessness. That's what exactly happens. And some other positions, forward lean standing, and standing with the back support. So some other breathing strategies, which is actually more popular, is pursed lip breathing. So you might have actually heard your healthcare professional say to you, make yourself comfortable sitting position, and chin in the neutral position, and resting arm position. Breathe in through your nose and breathe out through your pursed lip for 4 counts. So breathe in 2 through your nose and breathe out 4 through your mouth. So you have to actually give clear instructions. Your breathing out should be twice as much as breathing in. So breathe in 2 and breathe out 4. It need not be 2 and 4. It is twice as much as you're breathing in. It can be breathing in 3, breathing out 6. It depends on your patient population, how hyperventilated, hyperinflated they are, and based on that you prescribe your pursed lip breathing. And the other breathing setting is diaphragmatic breathing, which is also called as belly breathing. So inhaling in, and the lung fills the air in, and the diaphragm moves down, and the belly is out. And then when you're exhaling out, the belly goes in. So to make the patients aware of themselves of the belly breathing, ask your patient to keep one hand on your chest, the other hand on the upper abdomen, and then ask them to perform the same way. Breathe in, see your hand moving out, hand on your upper abdomen moving out, and then breathe out, see your hand on your upper abdomen moving in. And also you can make them aware of the chest. So breathing in, your chest moves out. Breathing out, the chest falls down. So you can instruct either way. And the other few options you can prescribe to your patients would be the 5-minute meditation and some yoga practices, which we have actually enjoyed the International Yoga Day yesterday with Sujata Taladi, which is a great informative session. Yes, our patient group actually benefit from that yoga session. And the other option is the oxygen prescription. And the oxygen prescription is based on the 6-minute walk test, as I explained before, and also on their blood gas analysis. What does this mean? Your healthcare provider would actually take a sample of blood and assess how much of oxygen and carbon dioxide is in your blood, so that they can base their prescription of oxygen to make your life as much easier as possible, and make less breathless, and to make your organs function as normal, to lead a better quality of life. So the quality of life, when it comes, it's all what matters to the patient. So you're not alone. So you have to form a support group, and support group is the best way to get their anxiety and depression out of the way. So you know that you are not the only person. You don't have a stigma that when I'm going out, someone is looking at me, I am unique. No, no one is different. When you have a chronic respiratory group support group, you know that you are in a group. I am not alone. So that kind of support will actually motivate you to engage in your prescription of pulmonary rehabilitation and to lead a better quality of life. And it comes down without any doubt, self-management is a key. And to improve your quality of life, self-management around your smoking, your alcohol habits, your physical activity, and your exercise training, and if you are actually a person with high anxiety and depression, how frequently you're attending your counseling session, those are all coming under the self-management. And also your exacerbation, how well you're taking your medication, whether your inhalers have been checked and optimized frequently every 3 months to 6 months by your GP or your provider, whoever is responsible for prescribing. Those all comes under the self-management. And it goes without saying, without support, nothing can be possible. So your family member or the carer needs a better education as well in order to support you to attain this best quality of life. So the quality standards of pulmonary rehabilitation adults by BTS as 10 standards, and I'm not going to read all the standards which have been mentioned on this slide, but we can actually say one big question here. All the standards which are mentioned here doesn't focus on the mental health or integrated care. Okay, so there is a mention of exercise training, which is actually not defining the healthcare setting of a pulmonary rehabilitation definition of 2013. So there is no way a long-term behavior change only can be focused on a physical activity or exercise training. It needs a mental health and an integrated way of care. For example, the patient would be smoking. For example, the patient would be finding very awkward to go out, need a partner or a friend to go out. So where is the linking support groups? Where are the social workers to link them? So those are the bits and missing puzzles in the current standards of quality standards of BTS. And this standard is 2014. There is not much huge change in the standards now, which I can read through in the following slides. So are we defining the pulmonary rehabilitation in practice right? That's a big question I'm putting on to everyone who's actually watching this webinar today. So value-based pulmonary rehabilitation, how should it look? It should have an action plan. It should have an education. It should have a physical and psychological therapies. And it should have a self-management program. Yes, we are having those things here, but we are missing the psychological therapies in our current actions. And when it comes to self-management, we're not in an integrated way. So integrated care is missing. So if we are missing an integrated care, we are missing out the quality, we are missing out the accessibility, we are missing out the engagement from our patient group, and it is not cost effective, and we are lost somewhere. Okay, so what is a pulmonary rehabilitation should look like? It should look like a one-stop shop, and more than just an exercise program. Pulmonary rehabilitation should have all these actually staggered under each of their domains, which I mentioned earlier. Action plan, it should have a clear action plan to support the symptoms, optimize medication, and manage exacerbation. And when it comes to the education, both the patient and the family should receive the knowledge and skills training, exacerbation symptom management. And the physical and psychological therapy should actually be more prescribed and more in line with what matters to the patient, rather than you prescribe a standard way of prescription of physical activity. And they should be having some behavioral change support and tools during their prescription as well. And the final thing, the self-management part of it, should be focused on family and the patient care support and knowledge and skills, symptoms training, and exacerbation, emotion and behavior change training should be provided to both the family, both the patient and the family or the carer. So pulmonary rehabilitation, so far as I've spoken in the last few slides, you might have understood it is an integrated care. And I don't need to explain that or say it again. I'll mention it in the following slides again. So it is not a one-man show, okay? So it is an integrated teamwork, And we all are planning towards patient goals, patient improvement, patient quality of life, and defining these three main indicators. But we also need most of the pulmonary rehabilitation are not multidisciplinary. We need a multidisciplinary team assessment. Currently, most of the settings have physicians and nurses and physiotherapists or respiratory therapists according to the different countries and settings, but they don't have an integrated dietitian on all sites. They don't have all sites social worker. They don't have all sites pulmonary function technicians. They don't have all sites the smoking cessation officer and personal trainers or occupational therapist or speech and language therapist or counselor or a psychotherapist or psychologist. So those are the missing professionals in our team to make it as an integrated care providing a pulmonary rehabilitation, which we can define as a pulmonary rehabilitation. So one of the main person who can actually coordinate all this is named as a pulmonary rehab coordinator, which I played the role in St. Michael's Hospital in Dunleary in Ireland. So moving on to the next slide. So we are going to say, what is an integrated care package? I'm actually talking to you. What do you say about the integrated care? So this is the content I'm actually focusing on. There is a diversity, I understand, in terms of the content, mode, and delivery of pulmonary rehabilitation, but the content of an integrated care package should include a breathing training, inhaler medicine and technique optimization, oxygen and CO levels monitoring at a frequent levels as a standardized guidance by the BTS or as the international standards, and smoking cessation advisor sessions, respiratory muscle training, exercise prescription, health promotion advice and referrals, dietitian plans, counseling, and cognitive behavioral therapies. This should be a standard of integrated care package, and it can actually include more, but not less than this, which will actually not qualify for integrated care. And the duration should range from 4 weeks to 24 weeks, and it depends on the resources available in your own setting, and ideally at a minimum of 12 continuous sessions, and that is a must. And real impact requires a maintenance program for at least 3 to 6 months as an inpatient or outpatient setting, and depending on the local arrangements, wherever you are living. And delivery can be inpatient or an outpatient. And the reason more familiar delivery is the telehealth. So let's see what's the journey of pulmonary rehabilitation in the UK. In 2010, we all talked about the COPD consultation group, talked about expanding the pulmonary rehabilitation and integrating the pulmonary rehabilitation with cardiac rehabilitation, because both settings has exercise, but it's a different actually patient groups. So we are still confused on whether we have to integrate or not integrate. Okay, so we leave that question aside now. So 2018, then we moving on, we actually had this pulmonary rehabilitation service accreditation scheme. So why we had that service accreditation scheme is there was an audit conducted previously, and that actually highlighted only 42 out of every 100 patients completed pulmonary rehabilitation. So then the audit actually continued long, 2016, 15, 17, 18, and 19, the recent audit, there was actually, for the purpose of the pulmonary rehabilitation service accreditation scheme, they audited how many centers around UK providing pulmonary rehabilitation. I was surprised. England has 87% of pulmonary rehabilitation, and Wales has 5% of pulmonary rehabilitation. I'm living in Wales at the moment, for your information. I'm so shocked why Wales is having 5% of pulmonary rehabilitation, and Scotland has 8% of pulmonary rehabilitation. So this is actually a very inequality process in terms of the delivery of this pulmonary rehabilitation. And in Wales and Scotland, we need more centres of pulmonary rehabilitation to have inclusive pulmonary rehabilitation service provided to all the population, and all people have the right to receive this service. So NHS England and NHS Improvement actually have audited what are the challenges because this condition exists. The main challenges is lack of patient perspectives, low multidisciplinary working partnership at primary care, and lack of smart outcome measures. And integrated care setting is the main thing they are all now focusing on. They are all, and I would actually include as well, we are all focusing on integrated care systems. So what is that we have to be doing in order to avail the pulmonary rehabilitation services. If you are a patient, who prescribes the pulmonary rehabilitation service? Is it your physician or nurse or allied professionals, a physio or occupational therapist can prescribe a pulmonary, refer you to a pulmonary rehabilitation. And the most programs are located in the urban settings, and less are located on the rural settings. So urban has more actually benefits from the pulmonary rehabilitation centers. And COVID has created a telehealth program, a virtual rehab, bringing the care in patients' home, which is the main focus of the NHS, bringing the care closer to the home. And international respiratory societies also echo the same. So how you can actually get into the pulmonary rehabilitation program, but it is not an option for many. The reasons below are the poor local access, poor funding, or awareness of the pulmonary rehabilitation, patient-perceived logistic barriers, maybe the transport, maybe they actually having a stigma to work in a group, or maybe their timings, or maybe the setting of the pulmonary rehabilitation is very small and they don't like to enter the pulmonary rehabilitation. There are several reasons actually, and also the climate is another factor which has been researched in the pulmonary rehabilitation evidence. And the COVID pandemic, pulmonary rehabilitation settings are being closed, and most of the staff has to be moved from pulmonary rehabilitation to the front line and to the wards and the ICU setting, which actually curtail the intake, and we have a long waiting list of pulmonary rehabilitation. And also now, because of the COVID, patients actually have a stigma towards face-to-face pulmonary rehabilitation due to the risk of infection. So BTS has developed a guidance in delivering the pulmonary rehabilitation during the COVID setting, and also the international societies actually developed a guidance, instructions on how to provide pulmonary rehabilitation in their COVID-19, and they've categorized the different population which are the settings they can actually attend the pulmonary rehabilitation. And one of the key things for the long term, the post-discharge, the post-COVID rehabilitation, which is focus on the key performance index of the physical, psychological, and the respiratory impairments, require pulmonary rehabilitation in the outpatient settings or the home services or telehealth program for the first 6 to 8 weeks. My take on this, it is not to be limited to 6 to 8 weeks. It should be a long term, because we are going into an unknown of the COVID, and we had a great loss of humans as a result of COVID. And the people who are actually surviving the COVID and have been the warriors of COVID, we have those populations with us now, and we have to work them and build them back to strong. Any of the muscle rehabilitation or the psychological rehabilitation cannot happen in 6 to 8 weeks, and the period should be at least a minimum of 12 to 16 weeks to attain any benefits from the program. And as a result of the COVID, as I mentioned, we have actually made more of the virtual rehabilitation most places. And I put down here, there is a paper in 2016, the delivery of telerehabilitation service will also broaden the availability of pulmonary rehabilitation and maintenance strategies, especially to those living in remote areas and with no access to center-based exercise program. And this is proving that pulmonary rehabilitation is a main supportive tool. Telerehabilitation is a main supportive tool to reach out to the people who don't have the access to the center base. And there's also an insight that UK telemedicine market is on the high peak, delivering the virtual rehabilitation. And that is one of the good audit paper newsletter, which I've actually just highlighted here, which actually proves there is evidence that we are moving towards telerehabilitation to reach the rehab values to every door in the UK and nationally and internationally. And I also put down together a research newsletter on the moving pulmonary rehabilitation primary care. And this all talks about the current insights in the telerehabilitation and how we can move forward, taking the pulmonary rehabilitation into the primary care setting, which is very crucial. Telling the benefits of the pulmonary rehabilitation, I should not end the slide without mentioning that we have to consider the safety of the patient, whether the patient is a right patient population for virtual. If they have balance or cognitive issues, they will not be benefiting for virtual, and whether it's feasible or acceptable clinical improvements and patient engagement. These factors should be considered when you are recruiting a patient group for a virtual or remote or telepulmonary rehabilitation. So I'm proudly going to launch here, introduce my little baby, Lung Rehab Voyage, which is a pulmonary rehabilitation and mental health program provided virtually. And we have just started that very new. And the requirements for that is a confirmed diagnosis of chronic lung disease and a stable condition and with no cognitive issues, willingness to engage with the pulmonary rehabilitation prescription and recommendations, and the patient should have a digital literacy to some extent, able to operate their mobile phone or whatever their tele device they are having. And otherwise, if the patient is able to have a family member or a carer with a digital literacy knowledge, that with their consent, we can actually work with them. So this is our aim, to bring the care to the patient home, the pulmonary rehabilitation care, and to support a maximum number of people as much as possible to our efforts, and give the benefits of the pulmonary rehabilitation and mental health program. And that's the ultimate goal of the Lung Rehab Voyage. And the take-home message I would like to put down here: we all know the benefits of pulmonary rehabilitation. It lessens the intensity of breathing and leg fatigue. It improves the muscle strength and exercise capacity. It improves the quality of life. It reduces the frequency of exacerbation. It improves the functional status. It reduces the GP visits and hospitalization. Yes, it all has all these benefits. It doesn't have a capacity to reverse the damage of your lung, but we can actually prevent further damage for your lung. We always need to look a positive note. We can prevent any further damage by adapting a better healthy lifestyle with the pulmonary rehabilitation provider. So let's welcome the pulmonary rehabilitation care to our home and be responsible for our care. And the final slide, which I would like to, final two slides, is I've developed a chronic care model and a pulmonary rehabilitation service design, which I've also published. So my service design is focusing on the integrated care in a virtual care model. And I've just put the slide down here with all the information. So my service design will include a clinical information system, a delivery system redesign, and community services, healthcare organization, digital support, and self-management support. So the main concept is bringing the care closer to the home of the patient, and focusing on what matters to the patient. So how we can do is creating a pulmonary rehabilitation PAL, okay, PAL system, coding system, and a COPD passbook, which actually I focused on a COPD passbook because the majority of the population receiving the pulmonary rehabilitation is COPD, and I specialize in COPD population as well. So that's the reason this particular service design model, which I've actually designed, focuses on COPD passbook, to explain on that. So I'm focusing on the patient leadership, where the patient has the control over the COPD passbook virtually, and there will be a virtual medical case manager, online appointments and consultation, and rewards management system to make the patient engage. And also all the rehabilitation, including their prescription for physical activity and the mental health, CBT and mindfulness, will be online. And the recent developments, not recent development, last few years, we have social prescribing on the rise in United Kingdom. And we would like to incorporate the support from the social prescribing group, where the patient can have a tailored social support, and that should be tailored to each of the NHS trust or the health board, primary care, PR champions, and secondary care, PR case managers. These people actually interact with the social prescribing and actually design a holistic package to the patient virtually. So this is the whole idea or the concept behind it. And I've broken down into how this model of RAPRIS model works. You can have a little read on that. I'm not going to read through each of the steps here, and it is more clear and explanatory. I have actually inserted the link of my paper at the bottom of the slide here, and in your own time, you can go back to my paper and read about the design. And I would welcome the collaborators who would like to participate and work along with me to develop this further on. And thank you for listening. And please share your questions and comments or thoughts on the TMR YouTube channel or to the email of lungrehabvoyage21@gmail.com. I will try my best to answer to your questions to my best of my time. And also, I would see you next in the next webinar on the 24th of June. The topic is more muscle, more oxygen. I believe so. You wouldn't like to miss that one. Okay, I'll leave it now back to Mr. Sujata Taladi.
Maybe her network is slow.